The extraocular movement examination is one of the 5 ocular vital signs. An abnormality of the extraocular movements may reflect impaired function of the eye or other bodily systems. At the end of this activity, you will be able to demonstrate the ability to obtain and document an accurate extraocular movement examination on a patient with an acute eye complaint. You will also be able to describe the significance of the following extraocular movement abnormalities: an abduction deficit secondary to a cranial nerve 6 palsy, looking down and out with ptosis due to a cranial nerve 3 palsy, vertical diplopia, which worsens when looking down due to a cranial nerve 4 palsy, and intranuclear ophthalmoplegia, entrapment of the inferior rectus muscle. The first step in the extraocular movement examination is to position your eyes at the level of the patient's eyes at arm's length. Without moving your head, follow this object with your eyes. Also observe for any ptosis, which is eyelid drooping. In the patient's primary gaze, observe for any strabismus, which is abnormal alignment. Move the target in an H pattern. As you watch this video, note how the extraocular movement examination tests each of the extraocular muscles.
Basic eye movement exam that tests the function of each extraocular muscle by having the patient sequentially look in each of 6 cardinal directions, also referred to as the 6 cardinal fields of gaze. These are in, up and in, down and in, out, up and out, and finally down and out. The basic exam involves having the patient focus on an object that is positioned 18 to 24 inches in front of their face as you move the object through a large H shape to encompass the 6 cardinal fields of gaze. The eyes can be examined individually or together. In our example, both eyes will be tested at the same time. Begin by allowing the patient to focus on the object with both eyes in the primary position, that is, looking straight ahead, neither elevated nor depressed. Slowly move the object to the patient's left until you reach the limit of his field of view. Here, the patient's left eye should be fully abducted and the right eye should be fully adducted. This position tests the function of the left lateral rectus muscle and the right medial rectus muscle. Now move the object directly superiorly. This position tests the patient's left superior rectus muscle, up and out, and the right inferior oblique muscle, up and in. Continue by moving the object directly inferiorly to test the patient's left inferior rectus, down and out, and the right superior oblique muscle, down and in. Now return the object to the left horizontal position and slowly move it to an equivalent position on the right side. Here you can examine the function of the patient's right lateral rectus muscle, abduction, and the left medial rectus muscle, adduction. Again, raise the object directly superiorly to test the right superior rectus muscle, up and out, and the left inferior oblique muscle, up and in. Move the object directly inferiorly to complete the exam by testing the right inferior rectus, down and out, and the left superior oblique muscle, down and in. You have now tested the 6 cardinal fields of gaze for each eye.
As you complete the exam, ask the patient if they experienced any double vision. Double vision suggests a disconjugate gaze, and the cause should be determined. Causes include cranial nerve palsies such as 3, 4, or 6 nerve palsies, myasthenia gravis, thyroid eye disease, entrapment, or infection. You should also ask the patient if they experienced any pain as they completed the examination. Pain during this examination could represent an infection or inflammation within the orbit, thyroid eye disease, scleritis, or an orbital mass or tumor. A typical way to document a normal extraocular movement examination might be EOMI, which means extraocular movements intact, OU, or both eyes, full in all cardinal directions, smooth, no diplopia, no nystagmus, or pain. Examples you can place into the medical record: EOMI, OU, full ROM, no nystagmus, no diplopia, no pain. EOM's full and symmetric in 6 cardinal gaze, no pain with movement, no diplopia, no nystagmus.
Complete disruption of oculomotor nerve function, or third nerve palsy, results in paralysis of 4 extraocular muscles: superior rectus, inferior rectus, medial rectus, and inferior oblique. Patients with this disorder present with the ipsilateral eye stuck in the down and out position due to the fact that tonic activity of the intact lateral rectus muscle fully abducts the eye because it is no longer opposed by the medial rectus muscle. Further, the eye is depressed because the action of superior oblique is no longer opposed by the elevation normally provided to the abducted eye by the superior rectus muscle. Because lateral rectus and superior oblique are the only remaining functional muscles, the eye is unable to move from this position. Trochlear nerve function, or fourth nerve palsy, results in paralysis of the contralateral superior oblique muscle. The trochlear nerve is the only motor cranial nerve that decussates or crosses to the other side. Patients with this disorder are unable to depress the affected eye when it is adducted or in the primary position, due to the fact that the intact inferior rectus loses the ability to depress the eye as it is increasingly adducted. In addition, these patients are unable efficiently to intort the affected eye. Both of these lost functions can result in, quote, double vision. Many patients unconsciously compensate by tucking the chin, which eliminates the need to depress the affected eye, and tilting the head away from the affected eye, which eliminates the need to intort the affected eye. An eye movement exam of patients with trochlear nerve palsy reveals an inability to put the affected eye in the down and in position. Complete disruption of abducens nerve function, or sixth nerve palsy, causes paralysis of the ipsilateral lateral rectus muscle and an inability to fully abduct the affected eye. These patients typically experience double vision except during near vision when both eyes are directed inward. Eye movement exam reveals an inability to abduct the affected eye beyond the primary position. Some of these patients compensate by turning their head toward the injured side, which allows them to adduct the affected eye and pair it with the normal eye, which will be abducted.
This patient has an internuclear ophthalmoplegia. As he looks to his right, notice that the inward movement of the left eye lags behind the outward movement of the right eye. The patient will report that vision appears blurred or double as he looks to his right. Internuclear ophthalmoplegia is caused by a lesion of the medial longitudinal fasciculus in the brain stem. In young people, multiple sclerosis is often responsible. In older people, stroke is a common explanation.
This patient has diplopia on upward gaze due to inferior rectus entrapment by an orbital floor fracture on the right.